Welcome to Airway Breathing Conversation, a podcast presented by the anesthesiology residents at the University of Saskatchewan, created to provide individuals of all levels of medical knowledge with anesthesiology-related healthcare information. This episode is part of our Abridged Ground Round series, in which highly knowledgeable and sought-after guest speakers present on a multitude of fascinating topics relevant to anesthesia. Join us for Grand Rounds this week, where Dr. Janine Eckstein, an interventional and structural cardiologist at the University of Saskatchewan, discusses guideline changes to the antiplatelet management of revascularized coronary artery disease. Now, whether you are an anesthesiologist, resident, medical student, or member of the general public, come listen in as we demystify the incredible specialty that is anesthesiology, one episode at a time.
So I'm talking today about revascularization of coronary artery disease and antiplatelet management, because there are new 2023 guidelines. They were just announced at the Canadian Cardiovascular Congress, which was also combined with vascular disease as well as endocrinology at the end of October. They are online, but not yet in print. And what's also notable about them is that they are Canadian guidelines. They were a big panel. They have surgeons and cardiologists on it, and Dr. Jay Shavadia from Saskatoon was also on the writing group. So we're very happy to have him. So the objectives for today were to discuss invasive and non-invasive management of chronic coronary artery disease, as well as to discuss antiplatelet duration following revascularization based on the new guidelines, review some specific perioperative recommendations, and make good use of my vacation pictures to keep things interesting, because I am trying to use my pictures in every presentation for at least the next year. So if you're wondering why there's mountains, it has nothing to do with coronary disease. I just needed to put them in. So when we're talking about chest pain or angina, there were a few things that changed actually back in 2021, but they've been slow to catch on. And so if you do hear some new terms, and so the first few slides, I wanted to go over some new terms that you might hear, or new-ish. And so the old classification of chest pain and angina was typical, atypical, and non-cardiac. And that was based off of the Diamond-Forrester model of pretest probability of coronary disease. We took your age, we took your gender, and we took your pain description, which over to the right, there was kind of these three factors that we considered in your chest pain description. One of three meant it was non-cardiac or non-anginal. Two of the three meant it was atypical, and three of the three meant it was typical. Problem is that Diamond and Forrester was almost entirely Caucasian population. The age was only up to 69. It was not validated anyone over that, and anyone over the age of 80 was actually excluded from the model. And it's not great in women. It's not great in young people. It's not great in old people. And again, not great in anyone that's not Caucasian. The other thing that changed with that is that then they moved to cardiac, possible cardiac, and non-cardiac chest pain. And we did this move because too often atypical was being applied incorrectly, or not being applied correctly. And it was felt to imply a benign cause. So when we said atypical, because it wasn't atypical ischemic pain, people said it was fine. But under the atypical findings, which is often more stabbing or ripping or something like that, you can have a lot of actually very non-benign etiologies, both cardiac and non-cardiac. So the new movement is to call it cardiac, possible cardiac, or non-cardiac pain. And pain is kind of in these quotation marks because it's more often a pressure, ache, squeezing, or heavy type of a discomfort. The only good thing is if it's point tenderness, if they can point to it with one or two fingers, it's almost never cardiac on the great side. And when they've actually looked at more recent literature, because of this focus on making sure that we have better representation in literature and in guidelines, women actually present with a chest pain symptom almost as often as men, but they actually have a higher prevalence of accompanying symptoms like palpitations, jaw discomfort, neck discomfort, back pain, shoulder blade pain, or epigastric pain. More often, women actually come in with at least three of those. And so when they have all these discomforts, they tended to get shuffled into a different pathway where it was all over discomfort as opposed to being looked at as more ischemic. So it's actually a little bit of a misnomer that women don't present with chest discomfort. They do, but they have more often associated findings as well. And so chronic coronary artery disease, because that's what we're dealing with most of the time when we're talking about preoperative medicine, means any of the following. So people with left ventricular dysfunction due to coronary disease or an ischemic cardiomyopathy, basically. Stable angina, and so this is with or without imaging. So if they actually have stable angina, even if you haven't done an angiogram, but if they have very typical symptoms, you can basically label them as chronic CAD, and you should be treating them as if they are chronic CAD. If you have stable angina, and I underlined it, and evidence of coronary vasospasm or microvascular disease, that also counts as chronic coronary disease. Patients diagnosed with coronary disease on screening, so a positive stress test, a nuclear scan, a CTA, again, even if they haven't had invasive testing, if it's been done on screening and caught, they should be diagnosed as a chronic CAD patient. And anyone that's actually been discharged after an acute coronary syndrome or revascularization that have been stabilized. So it's actually a very quick transition. I don't usually call my patients chronic CAD until they're kind of a year out, but officially in the guidelines, as soon as they've been stabilized, even after an acute coronary syndrome, they become in that chronic CAD category. And I wanted to make a point of this because there's a lot of people walking around with this misnomer of microvascular disease. And so the evidence for a diagnosis of microvascular disease is 3 of the 4 or 4 of the 4, depending on whether we want to call it suspected or definite. And so you should have symptoms of ischemia, absence of obstructive coronary artery disease on either a CT or an invasive angiogram, and objective evidence of myocardial ischemia. So either an ischemic change on ECG or a wall motion abnormality when the discomfort is present. And if you really want to have it as a slam dunk definite, we are now bringing back microvascular testing. And so we don't have it in Saskatchewan yet. It'll be in Regina first. But there is testing that's come back that's actually looking at acetylcholine challenges. It was something that when the initial acetylcholine challenges were done years and years ago, didn't go over well because some people had VFib on the table and had really bad spasm. There's now new protocols, lower dose. We actually have wires that can go down the coronaries to measure coronary flow reserve. So you can actually have some people that have had the invasive testing done. It's very common in the States. There's a couple centers in Ontario doing it as well. So it will start to spread and we'll be able to actually give these people a better diagnosis and better treatment options. But there's a lot of people walking around with this diagnosis that may or may not actually have it. It's best to ask them, if they actually did have testing done, or if it was more of a, well, I didn't have anything in my arteries and I was having some chest pain. So they said I have microvascular disease, which is unfortunately quite common because we can never prove or disprove it. So a lot of people have that label. Some other terms to know, because I wasn't sure exactly what everybody would know. So I figured that most people would know acute coronary syndrome or ACS. SCAD is spontaneous coronary artery dissection. And ANOCA and MINOCA are the two that are coming bigger and bigger because of the focus on microvascular disease. So ANOCA is ischemia with non-obstructed coronary arteries. So you don't have anything significant in your arteries, but whether that's microvascular disease, whether that's spasm, there's a couple different entities that fall under that. SCAD falls under that. MINOCA is a myocardial infarct with non-obstructed coronary arteries, so an actual infarct as opposed to just ischemic symptoms. PCI, percutaneous coronary intervention, balloons, stents, etc. POBA, plain old balloon angioplasty. That is actually what it stands for, is plain old balloon. That's before we had stents, and now we still sometimes do it if we have to, particularly with drug-eluting balloons or DEBs. LM is just a left main. SVG is a saphenous vein graft. So that's when they took a vein to use a bypass. DAPT is dual antiplatelet therapy. SAPT is single antiplatelet therapy. Dual pathway, just to make it confusing, is single antiplatelet plus anticoagulant therapy. So that's what we think of in most of our patients with atrial fibrillation. ORCA, as most of any residents that have come through CCU with me will have heard, is actually only remaining coronary artery. So that is actually when somebody has, basically they've occluded almost everything else. They might be collateralized. They have one remaining coronary artery that they're living off of that collateralizes everything else. Road ablation. Road ablation is a specific type of complex cath procedure. It's actually a high-speed diamond-tipped drill. It sounds like a dentist drill. It actually drills a path through the calcium in the coronary arteries at around somewhere between 145 to 170,000 RPM, and does count as a complex PCI. And shockwave is the other thing that will often count as a complex PCI. It's intravascular lithotripsy. So we basically took the technology used to break up kidney stones, we put it in a balloon, and now we can use it in the legs for peripheral arterial disease or in the coronary arteries. So if you see some of those words, that'll be what they are, just out of interest. So the recommendations for chronic coronary disease, because I said I'd talk a little bit about that, are patient-centered care and shared decision-making that accounts for social determinants of health, including costs, travel, risks, testing, and treatment. And this is recommended in all management of chronic coronary disease. Because there's more and more pressure on actually looking at social determinants of health. Mental health has a huge impact. Multiple trips to hospital, particularly for people that are not in a primary center, is incredibly expensive, and people that are already underprivileged and have difficulties that way. And so looking at what we can do to manage that is very important, and talking about our patients about their options. Routine testing is not recommended. Specifically, it's not recommended to risk stratify or to guide decision-making unless the patient has a change in symptoms. So routine stress test is out. They can be used sometimes right after an MI, and so I use them most commonly in my post-CCU patients, somewhere between 3 to 12 months, to look at getting them back to exercise, but routine stress testing is not recommended anymore. The guidelines actually say move more or less sitting time. They say ideally at least 150 minutes of moderate intensity activity a week, 75 minutes if you're doing high intensity activity, or at the very least, less sitting time. So looking at step counters, looking at getting up more, anything that you can do to be less sedentary is helpful. Antiplatelet therapy, which is why I'm doing this today, because it is a bit of a mess. It can be longer, it can be shorter, or it can be the same as it was 10 years ago. And I'll go over some more of that in detail, but we really did both ways. We went shorter and longer at the same time, just to make it confusing for everybody. And one of the other ones that's really important for our younger patients is that beta blockers don't have to be for life anymore. You should have them if there's been an acute coronary syndrome within the last 12 months, although even that's in trials right now. You should have them if you have a low LVEF, or you might have them for another indication, arrhythmia, varices, things like that. But beta blockers, especially for young patients, do have a lot of side effects, including fatigue, sexual dysfunction, and patients really don't like them. And we used to say that once you're on them for life, and that doesn't have to be true for every patient. And so non-invasive management of chronic coronary disease. So the goals in chronic coronary disease are to reduce cardiac death. That's always our goal in cardiology. That's reducing death and morbidity and mortality is our goal in most of healthcare. So for reducing cardiac death, the things that have really been proven are managing mental health. A diagnosis of depression has a 2.1 increased hazard ratio for death, and including cardiovascular events. And so screening and then referring people on appropriately is one of the best ways of helping. And there is actually some evidence in small trials of treating people and that actually does reduce our cardiac death. As part of that, cardiac rehabilitation reduces depression related to chronic coronary disease or other events. And so getting people into cardiac rehab is a big thing. Aspirin reduces cardiac death, and then smoking cessation, lipid management, and blood pressure management are also all important in reducing cardiac death. The other thing we want to do is reduce the non-fatal ischemic events, which is where aspirin still comes in. Diet changes come in here. Smoking cessation, lipid management, blood pressure management, as well as diabetes management all reduce non-fatal ischemic events. And again, cardiac rehab gets a big plug here. Reducing progression of atherosclerosis is mostly about managing risk factors. It is about having conversations with your patients about assessing for therapy adherence and side effects. And again, looking at cardiac rehabilitation, because a big part of that is education. And then reducing symptoms and functional limitations. And so cardiac rehab wins on all of these levels. And then if you're looking at medical therapy, calcium channel blocker or beta blockers, used to be that we were all taught that it could only be beta blockers if it was an ischemic problem. Now, if your EF is more than 50% or basically normal, it actually says calcium channel blockers or beta blockers are equal first-line agents or long-acting nitrate. But I'll be honest, most people hate long-acting nitrates as a first-line agent. If they're still symptomatic after you've used one of them, add a second agent. If they're still symptomatic after the two of them, add a third agent, or consider ranolazine. By then, they're definitely under cardiology because that's a special access or at least a EDS type drug. And you can also consider invasive management. And invasive management, it's kind of down at the end of the list, despite the fact that I'm an interventionalist. I put it down there because it fixes symptoms. That is a medical therapy. It doesn't replace medical therapy. Medical therapy will change your mortality. It will reduce your non-fatal ischemic events. It'll do a lot of other things for you, but it will make you feel better. And that's what's important to some people. And that's what's really important to almost everybody, actually, and is part of shared decision-making. The strongest indicator of if I will make a person feel better after revascularization is how horrible they felt before. So the worse they feel, the more likely I am to make a difference. And revascularization can be with stents or PCI, or it can be through CABG. Unfortunately, with all the trials, and it's been for decades, and we've tried again and again. We tried with Courage trial, and then we'd have recent ischemia trial. We keep trying to prove, but we have yet to find that routine revascularization actually changes cardiac death. So currently, bringing them to the cath lab for a stable problem for chronic coronary disease does not reduce cardiac death, does not reduce MI, does not reduce hospitalizations for unstable angina, heart failure, or resuscitated cardiac arrests. This is a little bit tainted. None of those patients that have been studied are left main patients. None of them had an LVF less than 35% when we looked at conservative management versus invasive. And the vast majority of them did not have triple vessel disease. So there is some caveats there because we're too anxious to enroll those people in clinical trials. In patients with multivessel coronary disease and a low EF, PCI actually still didn't show improvement in MACE, but bypass surgery did. Probably because they can get to more small branches than I can. And overall, stents, the more you're putting in, the more metal you're putting in, they do run into longer term needing to do some, I like to call it touch-up work. So when you're talking about invasive management, excuse me, again, we want to look at shared decision-making tools and really remember that the most important management is non-invasive. But the shared decision-making tools is something that's coming out, and we're talking about shared decision-making more and more in coronary disease, in valve disease, and in all of medicine. And it involves not just education for the patient, but also actually having them presented with what their options are and asking what they want, what their goals in life are, and what is most important to them. And so a couple of organizations, some of the patient-related organizations, and also the American College of Cardiology have looked at making these shared decision-making aids, which can be printed off and supplied to your patient. These are the ones for stable angina. They made one slightly differently for class 1-2 angina versus 3-4. And basically it shows if you're looking at medicines alone or medicines plus stents, it goes over what your risks are during a stent procedure. It goes on what your risks are during the procedure, goes on what your risks are from the dual antiplatelet therapy, goes on about your benefits, and that also shows for both ones basically how symptoms would improve in 100 people with medicines and stents. And so if you look at either side, the blue is at 1 month, 6 months, and 1 year, how many people had symptoms improved with just medicines. The orange is added symptom improvement for people that also got stents. And then the gray is people who had no improvement. So you see that there's an ongoing improvement from medical management at 1 month, 6 months, and 1 year, and that the contribution from stents is low, but it's not nothing. And again, that's why it's up to the patient as well as the healthcare providers to kind of go over what goals are important for the patient and what they want to do. This is one that is Canadian from a shared decision-making tool. This is about primary prevention of aspirin, which I just wanted to show honestly because it's a Canadian shared decision-making tool that we've got. But basically it goes over the fact that if you, on the first left, is your major adverse cardiovascular events. So if you took aspirin, 81 milligrams every day, yes, you have an absolute risk reduction in cardiac events. But it comes at a cost of major GI bleeding, and it comes at a small cost of intracranial hemorrhage. So when you look at the numbers, it actually works out to basically no difference in terms of healthcare utilization. You may reduce your adverse cardiovascular events, but you increase your bleeding events. And again, it's about discussing with the patient what's most important to them, what's most worrisome to them, what would most affect their quality of life. And so these are really good tools that can be used with your patients, which is probably more for the GIM than the anesthesia because you're probably not having those long-term conversations, but I thought I'd throw in a bit for everybody. And so what are we doing about antiplatelets in 2023? Well, we talk about high bleeding risk. And so this is all from the new paper that was just released. So we talk about any one major criteria counts as high bleeding risk or any 2 minor criteria. And so these are fairly well known. We've been talking about them for a long time. It's just a slightly different presentation. If you've got end stage chronic kidney disease, so GFR less than 30, you actually have a major criteria, whereas minor is if you're moderate CKD. Cirrhosis, not usually a question. Active malignancy or spontaneous bleeding or a transfusion within the last 6 months or any point if it's been recurrent. Chronic bleeding problems, actually hemoglobin less than 110, moderate or severe baseline thrombocytopenia, so platelet count less than 100, prior spontaneous intracranial hemorrhage or traumatic in the last 12 months, or a stroke in less than 6 months, anticipated use of long-term anticoagulation, non-deferrable major surgery, or recent major surgery or trauma. So all of those count as high bleeding risk. And then the minor criteria includes these long-term use of oral NSAIDs. So a lot of our really bad arthritis patients, you'll hear it all the time. Tylenol doesn't do it. You'll have it in your patients coming for joint replacements. They want NSAIDs. They make a big difference to their pain. And so these are all high bleeding risk times. And then the other thing they wanted to find was what is a complex percutaneous intervention? Because it's always a goal of balancing your ischemic events and your thrombotic events. So we don't want stents to clot and cause another heart attack. We also don't want people to bleed and have a transfusion and have that extra stress. So when we're looking at complex PCI, we talk about if you had at least 3 different lesions treated, 3 stents deployed in the same procedure, more than 60 millimeters of stent, a 2-stent bifurcation strategy, which will be written in the report. If we do any intervention on a bypass graft, we use atherectomy. So that's where you're going to think about road ablation or shockwave, things like that. CTO, which is a chronic total occlusion. If those PCIs have been done, that's a lot of stent to do that. And sometimes in those procedures, we actually purposely go into the subintimal space of a vessel and then pop back in. So there's a lot of metal, there's a lot of layers of stuff going on, there's a lot of hematoma in there. So they're high risk PCI. Left main, and those are 3 different vessels being treated. So that's what we call a complex PCI. So they made these lovely charts, which are actually fairly simple. So we'll look at the acute coronary syndrome one first. They're simpler than what the US published about 5 years ago, at least. And so if we're looking at acute coronary syndrome, how long should we put them on dual antiplatelet therapy? Well, the standard for a long time and remains 12 months for standard. If you've had an acute coronary syndrome, this will reduce major adverse cardiac events. We've known this for over a decade. That hasn't changed. Then we get the extended people, which is what you'll be seeing more and more and more of. And that's why I said we really made it confusing. We made dual antiplatelet therapy longer at the same time as we made it shorter. And so if we extend dual antiplatelet therapy, we do decrease the risk of MI, stroke, death, stent thrombosis, and repeat revascularization if we include extended therapy up to 3 years. We know it comes at a higher cost of bleeding. That's not even a question. So it's appropriate for people who have high risk of repeat coronary events and low risk of bleeding. And if you do ever get someone who's on that extended therapy, it's okay to hold and restart the second antiplatelet for purposes of surgery. If they're on extended therapy, they're already in that range where they're past that stent safety zone. So if you need to hold something and restart, that's fine. This is a long-term game, not a short-term game. And if they do at any time develop bleeding on dual antiplatelet therapy of this extended therapy, you should just step them down. Because again, this is a long-term game. We're balancing ischemic risks versus bleeding risks. And that's a moving target at all times. The side that's really important here today is the de-escalation strategy. And so in patients at high bleeding risk, we are now talking more and more about de-escalation. We're talking about it sooner than we used to be. So now in patients at high bleeding risk, you can look at dual antiplatelet therapy for 1 to 3 months. So it's basically a minimum of 1, but preferable 3, with either changing your initial therapy from aspirin into Kegilor or aspirin and prasugrel, which we see really rarely, but will be coming around again. So basically you can de-escalate to just aspirin plus clopidogrel. That will be less bleeding. You want to get that first month in at least. That's the highest risk time for the stent. 3 months is even better if you can, but then de-escalating is an appropriate option. Or if you really need to, you can just step down to single antiplatelet therapy if they have no ischemic events in that first month. So you have to get them through that first month. That is still the highest risk time for the stent, but stents have gotten better and better. They are thinner. We've gotten better at knowing what we're doing when we put them in. We've gotten more strict about how we optimize them. So most of the time now, that first month is when most of that healing occurs. The preference is actually if you can do non-aspirin single antiplatelet therapy. It's a weak recommendation, but basically using clopidogrel alone instead of aspirin alone. There is more and more reports out there that clopidogrel as a single antiplatelet therapy might be less irritating to people than low-dose aspirin. And there's actually it was an open label trial. It was actually entirely Southeast Asians. And they actually had both reduced bleeding on clopidogrel and reduced thrombosis on single agent clopidogrel. So looking at those options is more and more common. If you have a complex PCI history or previous stent that's clotted off and thrombosed, you may not be appropriate for this shortened therapy. That's where some of that, again, shared decision-making and clinical knowledge comes in. But we are looking at de-escalating sooner and being more aggressive about that. And so when we're looking at elective PCI, when we look at these guys, standard is down to 6 months. So if you came in because you were a stable outpatient with CCS class 3 angina and you got a stent, the standard now is only 6 months. That 12 months time still gets written on a lot of reports, but 6 months is standard if you were a stable outpatient when you got your stents put in. You can also still extend these patients. So you can extend up to 3 years, same as the acute coronary syndromes, same thing. It's okay to hold it and restart if you need surgery. It's okay to step down and encourage to step down to single antiplatelet therapy if you have any problems with bleeding. And then de-escalation, very similar to acute coronary syndromes. If you have high bleeding risk, you can de-escalate to, in this case, we actually just say de-escalate to single antiplatelet therapy. And again, preference for clopidogrel if you can, but it's a weak recommendation. Overall, if they've had really complex stenting, maybe we don't want to step them down quite that soon. And then what if we never did any metal in them? What if we treated them medically? Because there's a lot of people that have type 1 MIs or type 2 MIs that are treated medically, either because they have very complex coronary disease that we can't fix, or because it wasn't their primary presentation and they've got other things going on. We decide to treat them medically. So we look at basically still treating with dual antiplatelet therapy, ideally for 12 months, but that is based on, again, benefits, risks. You do have to consider your bleeding risk and your ischemic risk. So these people, again, if you need to, you can step down earlier. And so we look at either prasugrel, which is actually usually too potent. So we prefer clopidogrel or ticagrelor over the more potent prasugrel. And so for perioperative guidelines, because that was the biggest things about dual antiplatelet therapy, but looking specifically at perioperative guidelines, this data comes a little bit from the ESC 2022 guidelines, and there's also some from the new 2023 guidelines, which looks at what are we doing for cardiovascular assessment and management of patients undergoing non-cardiac surgery. So this is a super long document. It talks about all sorts of surgery and everything. I tried to pick the most relevant points out. But basically we said, use the same indications for ICA, which is invasive coronary angiography in this setting, to revascularize preoperatively as in the non-surgical setting. So basically surgery shouldn't be unless it's an urgent surgery, but most surgery should not change how we manage chronic coronary disease patients. We want to look at if they had intolerable symptoms before a non-urgent surgery, we should be dealing with that. If they have intolerant symptoms and an urgent or emergent surgery, maybe we want to look at doing something like a CT. It's tough in Saskatchewan, I will give you that. Our wait time for a cardiac CT or a coronary CT angiogram in an outpatient setting can be up to a year. But they are getting better and better. I actually use a lot of the coronary CTs I've done as pre-screening for TAVI patients now. So we're actually not necessarily doing an invasive angiogram on TAVI patients. We actually screen them with a CT because we need it anyways for their peripheral access. And if they have coronary disease on that CT, then we'll proceed to doing an invasive angiogram. But the CT can give you a really good idea, especially of high-risk anatomy. It can tell you if there's a lot of calcium there. It can tell you if you're looking at a left main, and it can usually tell you if you've got proximal disease. And if you're looking at those words on a report, that's when you might want to consider that this is a higher risk patient. If it's mid and distal, that's not high risk. So you can look at doing a coronary CT angiogram, which is CCTA, to rule out coronary disease in patients with suspected chronic coronary syndromes or chronic CAD, or if you have a biomarker negative non-ST elevation ACS, so basically your unstable anginas. And you can use that instead of doing functional testing, particularly if they're not suitable for it, because a lot of our hips and knees, things like that, cannot walk on a treadmill. It's really good at finding that high risk stuff. The third recommendation is interesting. Preoperative invasive coronary angiography may be considered in stable chronic coronary syndrome patients undergoing elective surgical CEA. This is the only surgical procedure that says stable CCS patients may be considered. It's a 2B, so it's fairly weak. And it's interesting because I've looked for the evidence for this, and there was a trial that looked at CEA patients, and it did not come out positive in terms of a benefit of preoperative revascularization, but it still is in the guidelines that you could look at those patients as a 2B, so not strong. Otherwise, doing invasive coronary angiography is not recommended in stable patients undergoing low to intermediate risk surgery. So basically, treat them the same as, that's why I started with the chronic coronary disease recommendations at the start. Treat them the same as your usual chronic coronary disease patient. Medical management does most of the work there. PCI for symptoms that are intolerable, or if you're really worried about something high risk. And really the question is, and the question that gets asked a lot and should be asked a lot is it worth it to do revascularization pre-op? There are a lot of small studies, but it's been tough because there's a difference between urgent and non-urgent surgeries, and there's a difference between bypass surgery and stents. And so CAS study looked at CABG, so coronary bypass grafting. If you did that, it actually did reduce perioperative mortality, NMI, in patients undergoing a major non-cardiac surgery. The largest benefit was seen in patients with 3-vessel coronary disease and reduced EF. So there is some evidence saying that if you surgically revascularize these people before a major non-cardiac surgery, they may do better. It's really tough because finding people that fit in that box is extremely difficult, because going through a CABG is difficult and rehabbing from a CABG is difficult. And so when you're looking at these people that might be looking at a major non-cardiac surgery, it's tough to say that we can get in there and do a bypass surgery pre-op and then have them rehab appropriately before you're looking at your next surgery. CARP trial randomized patients to revascularization, either surgical or percutaneous, before major vascular surgery. It didn't show any benefit. No benefit in MI at 30 days, no change in mortality at 2.7 years. That's just where the majority of follow-up was ended. It did, however, exclude left main disease. There was about a third of the patients that had triple vessel disease, but altogether very low numbers. So we still have no way of commenting on left main disease or triple vessel disease and what we should do with those people preoperatively. There was a meta-analysis of just about 4,000 patients that said no benefit associated with routine prophylactic revascularization before non-cardiac surgery. And my favorite is actually a retrospective analysis of just over 4,000 patients that were undergoing total joint arthroplasty. They found an increased risk of CV events in patients with chronic coronary disease, regardless of revascularization status. But then when they went into detail, if you could predict that you need your joint arthroplasty in at least 2 years, if you received revascularization over 2 years before getting your joint surgery, you actually did have a decreased risk of CV events. So if you can start looking into the future and thinking that you're going to need a joint arthroplasty procedure in about 2 years, maybe you should get your revascularization now, which is the funniest thing I've seen in a trial in a long time, but it was a retrospective analysis with a lot of limitations, obviously. So when we looked at these guidelines, then we basically said, if you're looking at your antiplatelets and who you should revascularize, if you can delay, so if you have an elective non-cardiac surgery, you should put it off for at least 6 months after elective PCI, and this mirrors our outpatient guidelines from the Canadian system. So instead of 12 months now, if you were a stable outpatient, you can get away with 6 months. You're only required to have dual antiplatelet for 6 months. You can look at non-cardiac surgery after 6 months now as a stable outpatient. We still prefer 12 months after an acute coronary syndrome. If possible, if you have a time-sensitive surgery, we still prefer a month of dual antiplatelet therapy if you had stents put in. But again, not everything can be deferred for a month. If you can give me that month, great. If not, we can work with it. There are some IV medications, which have just recently become available in Canada, that can be used as bridging if we really need to. In patients with a recent PCI that are scheduled for non-cardiac surgery, it's obviously recommended that we have a discussion between the surgeon, anesthesiology, and a cardiologist. I would encourage that this be with the patient's primary cardiologist whenever possible, especially if it's non-urgent. And that's really because sometimes when you see them in the hospital, you don't know what we've done with these people in the office. Unfortunately, Saskatchewan does not have a unified EMR system. And so looking at maybe they've had a stress test in somebody's office or at St. Paul's or at RUH. The ones at RUH are actually on Citrix, but the ones at St. Paul's are hard to find. And so try and find their primary cardiologist, because maybe they know what that complex PCI has been. Maybe they know if they've had a stress test recently, and they can give you more data on what the patient has. So if at all possible, try and involve the primary cardiologist. Obviously, if it's urgent, you can call the cardiologist on call. The cardiac cath lab reports are on Citrix. And so I get a lot of calls about this and asking where they are. They are on Citrix. You can find them. If you look in any given admission, whether it's been an outpatient day surgery or an inpatient surgery, I know the inpatient admissions, I know it's long when you're looking at an inpatient admission on Citrix because you've got all these lists of everything. But it has the description of either cath lab report or cardiac cath lab. And it has that little icon just to the left, where if you click on that, it'll actually bring up the visual report. So it doesn't, if you just click on the name, it won't do it because it's been scanned into the system, but you can get them on Citrix and it is there. The last page of the report will always have some recommendations that say what we recommend for duration. And the longer paragraph you see on the report, usually the more complex it has been. So if you see 3 lines, it was probably really short and easy. If you see 2 paragraphs, or if you see a lot of capital letters, you should probably talk to somebody if you're needing to consider changes to their antiplatelet therapy. So that's something that you can definitely do. And it should always be a discussion. In patients with a previous stent, it is recommended to continue aspirin if at all possible. They do make a caveat that if you are a high bleeding risk surgery, particularly in a closed cavity, so intracranial surgery, spinal surgery, retinal surgery, they do actually say you probably should interrupt aspirin for at least 7 days, if at all possible, because of the risk in those places. And then if you do interrupt antiplatelet therapy, it's recommended that you restart it. So this is something that we're seeing more and more. If you have to, after 1 or 3 months, if you have to temporarily hold it. Just make sure that it gets restarted post-surgery, preferably within 48 hours. Obviously, that depends on the surgeon's comfort. But if we're looking at holding the medications, you want to withhold it. Everyone gives a little bit different recommendations, but ticagrelor for 3 to 5 days, clopidogrel for 5 days, and prasugrel for 7 days. And you want to look at restarting it as soon as possible after the procedure. So if you want to make yourself as safe as you can hold it. You can hold it earlier than ever before. You can proceed with surgery, like I said, for elective patients at 6 months. But if you're holding those agents, make sure you do try to restart it post-operative so we can still finish their full course overall. And so the rules are a little funny. I have to say there's plenty of evidence, and there's been evidence for a long time saying that ticagrelor doesn't actually need as long as clopidogrel or prasugrel, although people are more afraid of ticagrelor. There's lots of evidence saying you will bleed more if it has not been held for at least 48 hours. So ticagrelor is very potent. You will get more bleeding if you have not had it out of your system for at least 48 hours. But overall, it is actually reasonable at 3 to 5 days. And there is a movement to look at a bit more. I know Perfusion does some TAG testing. There's a couple different little packages or modules that come with that. And there are some that can look specifically at antiplatelets versus just the global coagulation profile. And that's really important for some of these intensive care patients, because when you're critically ill, some of your coagulation parameters can be off because of your critical illness. But there are cartridges that will just look at your antiplatelet activity and give you an idea of how much is left there. Because that's always been a difficulty is what we're seeing, especially in our CCU patients that we're talking about going for bypass, is what we're seeing still residual antiplatelet activity, or is it just that overall their system is stressed and they can't make the same clotting factors? And I think neurosurgery is actually beating us to those to that testing. So they should be the first ones to have the testing available as a fairly quick point of care testing. I think it's available within 30 minutes for the antiplatelet cartridge. This is the Canadian guidelines. This is for cardiac surgery recommendations. So they did actually have some cardiac surgeons on the panel that looked at what you should do for discontinuation of ticagrelor or clopidogrel. They were actually quite aggressive. They said that you could proceed with a cardiac surgery with holding clopidogrel for between 2 to 7 days. And they said ticagrelor for 2 to 3 before surgery. So the Canadians were actually very aggressive in terms of this. I don't think that our guys, when I've talked to them, are in the position to be quite this aggressive, but it is something we're moving again more and more towards this management. We still do like to continue aspirin in all of these patients. And looking at antiplatelets following bypass. This is one that, again, I put in more for the GIM people that are here today and I guess actually also because I had a phone call yesterday. My office got a phone call yesterday from someone from Anesthesia because I have a patient looking at elective surgery who had a recent bypass in September, and they're on dual antiplatelet therapy. So we used to just say if you had CABG, you were revascularized, you got on aspirin. Now we are seeing that there is a difference in graft patency if you take dual antiplatelet therapies. So you will be seeing more and more patients following a bypass that are put on dual antiplatelet therapy for 12 months. And because it improves graft patency, and in off-pump patients, it actually reduced MACE. This is something you will not see in Saskatchewan. We don't do anybody off-pump in Saskatchewan. I believe Ottawa does off-pumps. Quebec has a number of centers that are doing off-pumps, and the States obviously has a number of people. It's not in Saskatchewan yet, but in those people, it's very, very important because you're actually looking at a decrease in MACE if you continue dual antiplatelet therapy. And it's the same overall, though. If they are a high bleeding risk, you can consider shorter dual antiplatelet therapy, or you can consider single antiplatelet therapy because bleeding is important and bleeding does kill. And if you need a non-cardiac surgery after bypass, you can proceed with that. So the duration of this dual antiplatelet therapy can be adjusted depending on your individual ischemic risks and your individual bleeding risks and shared decision making. Because again, this will improve graft patency, but some people, and I've certainly had some people that actually chose bypass as a revascularization method because they knew that it would actually get them to their joint replacement sooner. So I've had some people that knew that bypass a few years ago, you didn't need dual antiplatelet therapy for as long as you needed it for a stent. And so they would prefer bypass surgery so that they could then go on sooner to their joint replacement. So it is all about shared decision-making, balancing those risks. If you are going to go for a non-cardiac surgery after bypass within that first year, you want to hold and restart that dual antiplatelet therapy as soon as possible post-op, just like all the other ones. And looking at, again, whether they have normal EF or things like that will change what your risk parameters are for going ahead with that surgery. These are a couple different ways of looking at the same concept, but ESC actually is a pretty nice breakdown of these. So if we are looking at your patient on dual antiplatelet therapy, first we want to go with preoperative risk. What is their bleeding risk related to a non-cardiac surgery? Is it high bleeding risk? If yes, then you go towards thinking about their thrombotic risk. If it's not a high bleeding risk surgery, you go down this side on the no, and you just continue dual antiplatelet therapy. Excuse me, sorry. If it is a high bleeding risk surgery, then you look at your thrombotic risk. Have you had a stent within a month? Have you had an acute coronary syndrome within 3 months? Are they at high risk of stent thrombosis, which is where you're thinking about these high risk PCI, high risk coronary interventions, things like that. If they are not at a high thrombotic risk, then the recommendation is to continue aspirin and again, interrupt the second antiplatelet and then restart as soon as possible post-op. So it's all about when we talk about holding or interrupting, making sure that we emphasize that it should be restarted. If this person is both a high bleeding risk and a high thrombotic risk, and the surgery is time sensitive, this is where you will either see that you should defer if possible, but again, that always depends on if it's really truly time sensitive or not. And if it is truly time sensitive, there is this option which is coming out talking about bridging with either GPIs or cangrelor. That actually came out as a discussion last night on a WhatsApp group of Canadian interventionalists, where Edmonton just got cangrelor yesterday. Ontario has it. It is coming. It is an IV option that can be used. And so that will be something that is an option if you have that very high thrombotic risk patient, but also have a very time sensitive surgery. And it will be coming out. I personally like this one. And I think this one, if you're talking about it with patients, makes a bit nicer of a look. So if you have to interrupt your dual antiplatelet therapy for an elective non-cardiac surgery, are you looking at, was it an ACS at your PCI, or were there any other high-risk features? And that puts you in the no or yes category. And so class 3, which like I said, I like this one for patients because most people get that red is bad and green is good. So if you're looking at an elective non-cardiac surgery and you had an acute coronary syndrome, then you're on the right here. You would prefer not to proceed with an elective non-cardiac surgery for 3 months. And that's because red is bad. Obviously, between 3 to 6 months, you're in that orange 2B range. After 6 months, you're in a 2A, and class 1, 12 months. So it's kind of your increasing margin of safety if you're looking at an elective non-cardiac surgery. If you had no acute coronary syndrome. If this was just a stable patient, then you get to be this side over here. 1 month, we still don't want you in there at 1 month if it's an elective non-cardiac surgery. And then between 1 to 6 months is your yellow, orangey zone. Actually, these guys just get yellow. And then after 6 months, you can go ahead. So this is a nice, simple one that I like. Again, stable outpatients on the left, acute coronary syndrome on the right, red, orange, yellow, green for when you can proceed for an elective surgery. And so that was a lot, and I wanted to leave some time for discussion and questions. I actually wanted to make sure I left a lot of time because I know the memo said people have to get to the OR by 8:30, so to end and make sure I had some time for discussion. So in conclusion, the points I kind of wanted to emphasize was that chronic coronary artery disease does not necessarily need a stent. Non-invasive management is key. PCI won't change your risk of MI, stroke, or death, but it definitely does help symptoms, and that does matter, and it matters to patients, and it matters to us. It does not reduce preoperative risk, with the caveat that most trials excluded left main disease and were limited in terms of the numbers of patients with 3 vessel disease. And it's very important to have this shared decision-making discussion with your patients about the risks and benefits. Antiplatelet therapy, like I said, we just decided to go both shorter and longer at the same time. But if you've got a stable patient, 6 months and you're free. If you've got a high bleeding risk patient, we can go as low as 1 to 3 months. But at the same time, if you're a high ischemic risk and low bleeding risk, we can go up to 3 years. And if you're in that longer session, and I always tell my patients, although I know it's different for everybody, and I always write it on my notes, but I know that honestly, I don't think those get to you guys very often, unfortunately. But I will always write on my notes if I have someone on extended therapy, and I will tell them, if you need a surgery, you can start it and you can stop it and restart. And if you have bleeding, you just stop. But again, I know that it's tough for you guys to get notes and things like that. If you see these words, so if you see ORCA, which like I said was only remaining coronary artery, if you see rotablation, shockwave, left main, CTO, SVG or vein graft PCI, or if your patient says they got more than 3 stents in at once, patients love knowing how many stents they get. Even if I say, well, they're all overlapping, and I say I could put in 10 8mm ones, or I could put in 2 40mm ones. They love knowing how many stents they have. So if your patient says they got more than 3 stents at once, it's best to talk to the patient's primary cardiologist if it's non-urgent, or the cardiologist on call if it is urgent, about what to do with their antiplatelet therapy. Because those mean you're all looking at a higher risk of ischemia and kind of a situation. If you're going to do single antiplatelet, consider clopidogrel. It's up to obviously the surgeon and how they feel. And again, remember that the East Asian population may actually do better, both less bleeding and less thrombosis, on Plavix monotherapy instead of aspirin. It's a single large trial, but there is evidence, and there's a lot of anecdotal evidence to this effect as well. And preoperative revascularization does not reduce risk, but again, that still has a caveat in high-risk patients. And so if you've got someone with absolutely intolerable, unstable symptoms, or you put them through a coronary CT angiogram and you have that finding of high-risk disease, those people, if you can defer surgery, may be better with revascularization, looking at discussions and shared decision-making and risks and balances.
You've been listening to Airway Breathing Conversation, a podcast hosted and presented by the anesthesiology residents at the University of Saskatchewan. Please note that while this podcast is run by healthcare professionals, it is intended for educational and entertainment purposes only. We are very thankful to our guests for taking the time to share their wisdom with us this episode, and a very special thanks to you, our listeners, for tuning in. Don't forget to follow us and our associated USask Anesthesia accounts on social media. You can find all our social media links on our Linktree page at linktr.ee/abc_podcast. You can also find the department's social media links on their Linktree page at linktr.ee/usask_anesthesia. We'll see you next episode, but until then, stay calm, take a breath, and always remember your ABCs.